wanted to chat about how I think about alcohol use in patients who are coming into the hospital. So basically, acute complications and management thereof. Obviously, alcohol can mess with everything, whole body wise, and there's a ton of other considerations that are more applicable to the outpatient setting, but I was going to focus more on inpatient stuff. And the reason why is because these can creep up on you, they can surprise you, and additionally, I think it's worth, my usual habit or pattern is every time I admit somebody who I'm concerned about the amount of alcohol that they use, I run through this whole list in my head every time with every single one of them. Now, how often do they have like all of these things or multiple of them? Not all the time, but I'm more likely to think about and catch certain things, and it just serves as a refresher so I stay sharp on this to catch the stuff in the future, right? So there are a couple different ways that you can organize this. I've done it before where I just think about, hey, let's just like go from head to toe. What kind of complications can happen? Or if you wanted to do like ICU style, like systems-based kind of order, and think about how is this system affected by this thing. That's another way to do it. So I think that that's a fine way to go. We can do it that way for today. So we have a patient who has a history of or ongoing heavy alcohol use, and so we can start our first, the typical. What's your first system that you typically use in the NICU? Is neuro, right? Yeah. So what are the neurological complications that you would be worried about in a patient with alcohol use disorder? Wernicke's encephalopathy? Okay, cool. So Wernicke's, what is the bottom line, simplified mechanistic driver of that process? Yeah, thiamine deficiency. And what are some of the manifestations that you think about? The things that might tip you off, because it's not always super obvious. Confabulation can happen. That's more often associated with the later, longer term, more Korsakoff syndrome sort of thing. But they're going to be making little sense. Sure. Okay. What else?
Is the movement with the Korsakoff as well, or is that also?
What movement are you getting at?
Like ataxia.
Ataxia?
Yeah.
Sure. And ataxia can be multifactorial, right? You can have ataxia because you're actively intoxicated. You can have ataxia because you can get alcohol-related, cerebellar degeneration and things like that. You can have ataxia from Wernicke's. So there's some overlap to these things, and it can be tricky. You can even have ataxia from alcohol-related neuropathy and things like that. So there's multiple reasons why you can have ataxia. There's some ocular stuff, ophthalmoplegia, that can develop, etc. I think that you don't have to obsess over this diagnosis a ton. So you just have to think about it. And if you get any whiff of it, again, what is the treatment for Wernicke's?
500 TID, right?
Thiamine, 500 milligrams IV TID. How does that compare to our normal thiamine replacement that we give people in the hospital?
1 milligram a day.
100 milligrams. You're thinking of folate as 1 milligram more often, right? But so yeah, oral thiamine in the hospital is often 100 mg per day. And there's not actually RCT evidence for any of this stuff. It's kind of like historic. A lot of it's tradition made up. But in patients with more severe complications, be aggressive. There's essentially no risk to giving somebody thiamine. The other mistake that sometimes people make is thinking that a banana bag will do it. I don't use banana bags ever. It's basically a bag of LR with some mag and some thiamine, some vitamins in there that you infuse slowly. I'd rather just get the thiamine in quick, and if I feel like they need crystalloid, if I feel like they need fluid, I'll give it to them separately. There's not really a benefit, even though it sounds convenient, and you get your yellow Gatorade-looking bag that looks satisfying, but I don't use them. Just regular crystalloid if you need crystalloid, and then give them their thiamine IV separately, and that's Q8, 3 times a day, for at least a few days, and then you drop it down and kind of taper it from there. So that's one of the neurological issues. So Wernicke's, and then we said the more long-term complication of the Korsakoff psychosis and confabulation and all that. Okay, what other neurological things do you think about?
Decreased affect.
So mood disorders.
Yeah.
Sure, you can have substance-induced mood disorders, so it's worth doing your standard evaluation on that, checking for safety and suicide risk and things like that. Okay, what else? Alcoholic hallucinosis, right? Sure. Okay.
What about the delirium tremens?
Delirium tremens and just withdrawal in general, right? So withdrawal syndrome, which can include hallucinosis, can include seizures, DTs, where you start to get a lot more autonomic instability and things like that, right? So you guys know, how we do CWA assessments for patients to track the severity, and then management. How do you typically approach management? Ativan, so lorazepam is commonly used. It generally does the job. It's probably not the best medicine for this, but it's probably the most commonly used. There are some advantages to other medications. So I've listened to some EM folks actually talking about how they prefer diazepam in the ER. So you want something that's fast on, right? You want something that's fast on, and you would prefer it to have a little bit longer duration of action. So lorazepam tends to be pretty fast on and also relatively short. Some other medications, diazepam in particular, seems to be relatively fast on, but lingers around a little bit longer. And so some EM folks that I've listened to seem to prefer that. And there's actually a swing back of the pendulum, it seems, back towards phenobarb is getting popular again. I've used phenobarb a couple times in patients. Typically, it can be a little tougher on the wards because it's not something that's super readily available. Like pharmacy has to, prepare it and get it to you and stuff, and it's something that needs to be. Your goal is to load people with phenobarb, and then it self-tapers. It's a very, very long-acting thing, right? So there's some dosing stuff that we don't need to go over that you could look up if you're ever in a situation where you need to use it. There have been some lorazepam shortages and some other things like that that have led to situations where I was like, okay, let's just load them up with phenobarb and then let it self-taper from there. And then the other advantage, the other nice thing with phenobarb is that drug levels are meaningful. So you can actually draw a blood level and you can be like, they're therapeutic, I'm done. I don't need to give any more. Whereas lorazepam, you can't do that, right? So there's some interesting stuff there with withdrawal. So Wernicke's, withdrawal, the whole spectrum, hallucinosis, seizures, DTs, that whole deal. Wernicke's, Korsakoff's. There's also, as I mentioned, neuropathies that can happen. So I've had patients who came in with foot drop and stuff like that and end up being related to alcohol-related neuropathy. It can also be sensory, super painful is another issue that can happen. What else? We mentioned mood disorders. There's a few things. Okay, there's probably more, but that's good enough for now. As far as what I'm thinking of up front when we're talking to somebody in the ER with heavy alcohol use. What's the next system that you go to in your MICI presentations?
Heart.
Yeah, cardiovascular. Okay, cardiovascular complications of alcohol use. What do you think of? Dilated cardiomyopathy? Okay, sure. Dilated cardiomyopathy, or also related to thiamine, you can get, as we said, wet beriberi. We talked about that the other day. Beriberi. That's like a high output heart failure kind of situation, which can look different than a plain old dilated cardiomyopathy with a low output. What else? AFib. Really good, yeah. So anytime you see any patient with new onset AFib, this extends to primary care clinic as well. Questions I'm asking them, how much alcohol do you use? Big time, for sure. Thinking about alcohol in new onset AFib, obesity, untreated sleep apnea, thyrotoxicosis, things like that. Those are things that you should be asking. And then valvular disease would be another thing, right? Okay, hypertension is another thing. And alcohol itself can drive hypertension. That's more in the outpatient setting. If I have anybody with hypertension, ask them about alcohol, same thing. Sleep apnea, obesity, all these other same things, they run together. In the hospital, the hypertensive relationship tends to be more on the side of withdrawal. And we talked about this the other day, right? Where you might admit somebody, maybe you don't get a good alcohol history when they first come in. You admit them and you're managing them for whatever other reason they're in the hospital. And then like day 2, day 3, maybe if they had been drinking up until their hospitalization, now they're getting to that like 72-hour time point, you start to see their blood pressure start creeping up. That's something that caught my attention in that other patient. I started to notice this patient came in with a fine blood pressure. Now they're like 160, 170, and they've been in the hospital for approaching 2-3 days now. I'm gonna go re-ask them again about alcohol because that can definitely drive that. Of course, that's not the only thing that can do that in the hospital, but that should be high on your list because that can be one of the earliest findings and you wanna catch that before they start seizing on you, right?
Right.
I've had patients with alcohol withdrawal who look like they were septic. Full-on SIRS, tachycardia, hypertension, fevering, like all of that stuff. you can see it can be pretty dramatic in some patients, so worth thinking about. Anything else cardiovascular-wise? Fib, hypertension, heart failure. I think that's good for now. Next, usually do pulm. Anything pulmonary that you think of? not a ton. There's not a lot of direct alcohol toxicity on the lungs, but there are complications, so it can cause aspiration. That's probably the main one. You can get an aspiration pneumonitis or outright pneumonia from it. That's probably like the main one that I would think about. The other thing would be like if they co-ingested alcohol with other respiratory depressants and they were, hypoventilating or something like that. But I'll say aspiration. What do you want to do next? GI?
Yeah.
GI. What GI complications of alcohol use do you think of?
All of it.
Enteritis, esophagitis, gastritis, sure, vomiting. Okay, cool. Which itself can then lead to what? Mallory-Weiss tears or your Borhave syndrome, things like that, right? Okay, cool. What other GI complications? GI is a big system. It's complicated. You can divide it if you wanted to into like luminal pathology or extraluminal, right? So we're doing luminal with the vomiting, tears, bleeds, ulcers, things like that, and then extraluminal would be other GI organs, right? So what are we getting at there?
Yeah, cirrhosis.
Cirrhosis,
Alcohol, hepatitis.
Alcep. Well, so cirrhosis, all the ways cirrhosis can decompensate, right? So your ascites, variceal bleeds, encephalopathy. Okay.
Diarrhea.
Diarrhea, I mean, maybe, but
No.
not really like a super typical way that they'll come into the hospital, at least. Pancreatitis, though.
Bronchitis.
And you can have acute pancreatitis due to heavy alcohol use, or you can have chronic pancreatitis from recurring acute pancreatitis, and definitely somebody with chronic pancreatitis I'd expect to have diarrhea from malabsorption, right? So there's one way you can get there, I suppose, right? He's like, yeah, that's what I meant.
That's exactly
what Okay. So what else? GI. We've done our luminal stuff, liver stuff, and then some teaching points that we came up with our patient that we're managing right now. So he has definitely decompensated cirrhosis, secondary to alcohol use, and we just mentioned the 3 ways it can decompensate. Just to refresh your memory, what are the 3 ways that cirrhosis can decompensate that we look for?
Is it the pre-renal insurenal that you were talking about?
No, cirrhosis decompensation.
Gotcha.
So ascites, variceal bleeds, and hepatic encephalopathy. Those are the things that we see that would qualify somebody as saying they have decompensated. They can have any number of those. Our patient came in with new onset ascites. He did not have any bleeding, nor did he have encephalopathy. So those are the big 3 that you look for. And then alcohol-related hepatitis is a slightly different entity, right? You don't actually have to have cirrhosis to have that. You can have that without cirrhosis. It is typically a subacute problem. This was like our main learning point from this case, was
Yes.
what you took away, right? Because when you guys admitted him, you wanted to start steroids,
Yeah.
and I said, hold off, let's take our time, right? So it's typically a subacute thing. Patients, if you get their history, they will have maybe increased their alcohol use more substantially in the preceding weeks to months. So it's not necessarily like I binged yesterday and now I'm here with alcohol, right? It can be, but it's more of a subacute kind of thing a lot of the time. It's more the hepatitis aspect, pretty inflammatory. So you look for the elevated transaminases, typically like maybe in the 200s, maybe 300s range, most often. If it's like 1,000, I'm looking for other simultaneous insults or something like that, right? It takes a lot to drive your transaminases that high, but it's still possible. So typically more in this like 100, 200, 300 range. Tenderness, new onset or worsening jaundice. They may have fever, they may have leukocytosis, they may look infected or septic or something like that, right? And so that's why, like I said, since there is some evidence for the use of steroids, which is at least you start out with like a month-long course up front, you definitely want to make sure they don't have an infection before you are to start that. And there's not benefit to starting steroids, like a time to first steroid dose. That's why we said we can take our time, we can do the infectious workup, we can do the paracentesis, make sure there's no infection in there, and then kind of go from there before we actually start the steroids, right? And then I also said that the steroids are the thing that we think of first because it's like the thing that we can do most easily, most quickly, but the benefit of it pales in comparison to the benefit of getting patients off of alcohol and nutrition and making sure they don't have an infection. All those things are going to be the things that kill them more compared to not getting steroids. The effect of that is tiny, tiny, tiny in comparison. So that was why with our patient, we said, hold off on steroids, do the infectious evaluation, get him really good nutrition as much as we could, high protein, added to bedtime snack, this other stuff to get some of that in him. And then getting him off of alcohol, which involved some counseling. And then we've also directly addressed alcohol use disorder, and we've initiated now, prior to discharge, started treatment for it, right? Which we'll come back to. Okay, so that's the stuff on GI. What do you want to do next? GU?
Renal.
Renal? Okay.
Or did you want more US?
This is fine. I don't think I have much more there. Renal GU, what do you want to do there?
AKI.
Acute kidney injury from what? If you're thinking they're hypovolemic,
Hypovolemic.
probably the most
Anemia.
common one.
Mhm.
Anemia, a little less often as a sole cause, but yeah, okay. Sure, okay. So we'll say AKI, we'll say pre-renal. If they have cirrhosis, you might be worried about hepatorenal syndrome. It's at least always important to think about it, even though it's going to be the minority of AKI cases you see in the setting of cirrhosis. There's not a ton of other like direct alcohol toxicity, but there's a couple things that you can think about. All right, what's next? It's not like a perfect order, but musculoskeletal. Well, let's do ID. We'll just fill out a few
Or heme.
more.
Would heme be
Endo,
under renal, or would it be-
heme, MSK, and then maybe psych or something like that. Okay, ID. I mean, they're generally going to be immunocompromised, right? We mentioned the aspiration risk, although most aspirations don't result in pneumonia, but it's something that you would think about. If they have cirrhosis, they're extra immunocompromised. So, just infections.
Oh, SBP specifically.
Okay, SBP, aspiration, and then, like I said, I mean, I remember seeing in residency one case of cryptomeningitis in an HIV negative patient whose only risk factor was NASH cirrhosis. Didn't even drink.
Oh.
Had obesity, developed NASH cirrhosis, and was immunocompromised enough to get
From the fatty liver?
cryptomeningitis.
Jeez.
Yeah, so
What is SPP?
spontaneous bacterial peritonitis.
Gotcha.
So that's when you get ascites that gets infected. So yeah, cirrhosis is a substantially immunocompromising condition. Endo, anything endo that you think about? Not really so much in the hospital setting. Yeah, so you can get, pancreatic insufficiency, sure. In the primary care setting, this is very much not a hospital thing, but
You get hyperthyroidism. Does it have an influence on the CSH at all?
not so much on the thyroid. You can get gonadal dysfunction, so you can get hypogonadism. So like, you're probably going to see soldiers and men who come in with concerns about low testosterone, erectile stuff, whatever. Yeah, alcohol is a big question for those patients. Yep, for sure. So not a ton hospital-wise for endocrine though.
Would there be a female complaint with that, on the endo side of things, with hypogonadism?
Not so much that I think of.
Burn is like a aromatase, right? Like the burden of testosterone. There.
There's some direct suppression effect, and then if there's obesity and excess body fat, that tends to aromatize a lot of testosterone as well. So there's multiple mechanisms there. Yeah.
Gotcha.
Okay, heme. What kind of hematologic things?
Yeah, it's almost like.
Right. So that's what was. I mean, this. So this guy. I remember we were on call. This patient that we admitted, or you were admitting somebody else beforehand, and I looked up the ER list to see what was going on, and I saw this thing that said like they called medicine. I said, "What's going on?" Because this guy seems like he's going to come to us. I didn't know what was happening. I pulled up the labs and just glanced through the labs, and when I saw the white count of 3, the hemoglobin of 10, and the platelets of 50, I said, "Okay, you got a patient with cirrhosis." Like, just could figure it out just from just from that. Being just, it's not the only thing that can cause that, but playing the odds, it's the most likely thing that we see that would cause that kind of a lab pattern, right? The disproportionate thrombocytopenia is the thing that probably got my attention the most, right? So his white count could have been 5, could have been normal. His hemoglobin could have been 11 or 12, could have been okay, but the platelets of 50, 60, the first thing I'm thinking is this pseudothrombocytopenia, is this fake? Needs to be repeated, which is less, I mean, it's not like happens all the time, but you got to think about it. And then does this person have liver disease? There are, of course, many other potential causes. But yeah, pancytopenia. And then as far as your red blood cells, right, not only is your hemoglobin going to be low, but what are some of the RBC parameters going to look like? Like your MCV, for example, in a patient with alcohol use.
It's going to be elevated.
Elevated.
It's
Oh, because of
macrocytic. It's
B12.
macrocytic. Yeah, it's B12.
It's not always due to B12 folate.
Oh.
That makes you think of B12 and folate deficiency make you, you have that association with macrocytosis. But I would say, honestly, we checked this guy. Remember what this guy's B12 was? It was like 1,200 or something because of his liver dysfunction. That's a kind of artificially high. But yeah, you will very often check B12s and folates, and you'll be like nailing it. I know this is it because of the MCV, and then they'll be normal. So there's an independent effect even on the MCV, regardless of those. But those are also on the list. So you have multiple mechanisms for a high MCV. So pancytopenia, especially a potent impact on platelet counts, tend to be suppressed the most, particularly in patients who have portal hypertension, as our patient did, right? And then the MCV will tend to be elevated most often. Of course, patients can have multiple things, right? So if they have a ton of like chronic oozing gastropathy or something, and they're having a lot of chronic blood loss, then maybe that cancels it out, and they end up having more of a normocytic kind of thing. If they have one process that leads to microcytosis, one that leads to macrocytosis, and then MCV is that, it's a mean, so you can just end up in the middle. So you can have any MCV you want, but if I see somebody with pancytopenia, disproportionate thrombocytopenia, and a high MCV, I'm like, this is alcohol until proven otherwise, most of the time, right? Okay. Anything else heme-wise? I think that's most of the interesting stuff that can come out there.
Would any of this be like the anemia of chronic disease type of thing, where everything is normal that we're talking about as far as having if you have an ulceration from GI, that's the cancellation you're talking about?
If somebody's having chronic blood loss.
Okay.
Right. Anemia of chronic disease is a different thing. So anemia of chronic disease is more related to inflammation.
But I'm saying they've had alcohol disorder for years and years and years that they've battled, and so all the complications related to, does that now count as a chronic disease as far as the body's response physiologically?
Yeah. So I think the terminology may be confusing you there.
Okay.
So anemia of chronic disease doesn't just mean they have a chronic disease. It means that it is due to chronic inflammation.
Gotcha.
And that inflammation ends up basically sequestering iron.
Gotcha. That helps.
So those are patients who have high ferritins, low transferrins, low transferrin sats. They are functionally iron deficient because their body can't use the iron they have. They're not absolute iron deficient. And it's more due to inflammation. And inflammation can come from cirrhosis, if they have cirrhosis, can come from chronic kidney disease, chronic heart failure, cancer, HIV, rheumatic conditions like RA, lupus, et cetera, et cetera. So chronic inflammation is what drives that. It's not just having alcohol use disorder for a long time. So I would not expect alcohol use on its own to cause anemia of chronic disease, but if they had cirrhosis from it, then I could see that.
Gotcha.
Although there's multiple ways that they can become anemic. Blood loss is one that you'd want to rule out first, of course.
Okay.
Cool. MSK stuff, what do you think about there? Asterixis. I guess if you're calling that an MSK thing, I consider it more of a neurological thing. But that's a manifestation of hepatic encephalopathy we've talked about.
It's like fatty replacement of like muscle tissue.
Yeah, you can get alcohol-related myopathy. Yeah. So neuropathy and myopathy. Sarcopenia can happen in patients with cirrhosis, advanced liver disease, things like that.
Is it considered like spider angioma or something?
Spider angiomas, that's more of a vascular phenomenon that happens again in the setting of cirrhosis. That's not specific to alcohol, but since we're in this big category, right? Spider angiomas are a similar manifestation to what I talked about yesterday with like splanchnic vasodilation and other kind of vascular abnormalities that you can develop. That's really the main thing. We've talked about neuropathy, myopathy. And then psychiatric, we mentioned mood disorders. You can blend in other concomitant substance use if they're using other things as well. Yeah. So I think anything else that's jumping out at you that we've not talked about so far? There's obviously a lot. As far as like hyperacute things, like we're in the ER talking to this patient, things I want to make sure they don't have are the things that are most morbid, most treatable, right? So I'm thinking about Wernicke's. Do I need to load this person with thiamine to handle that, right? Do I think they aspirated? Do they have something going on there? Do they have heart failure of whatever variety, right? Any of these things. Do they have AFib that needs to be managed? Okay, pancreatitis, cirrhosis, and any of the ways that cirrhosis can decompensate. And that's probably like the major things that I'm thinking about immediately. Of course, there's lots of other things I'm thinking about beyond that. And then if you're seeing somebody in primary care, there's even more things you're thinking about beyond that. Mm-hmm. Preferably getting them hooked up with behavioral health, and then getting comfortable with the use of medications for alcohol use disorder, which I think every primary care doctor should be comfortable with. I don't know how comfortable you guys feel with these things as far as your training and use in them, but I think you should be. And so with this guy, we talked about what our options were. First line option for him would have been what?
What have been
would have been naltrexone, right? And you can use naltrexone PO, which is daily, at least, I think. It might be multiple times a day,
With
but I can't
Wellbutrin,
recall.
correct? The combo with naltrexone plus Wellbutrin?
No. So bupropion naltrexone, that's a combination product for the treatment of obesity.
Okay.
If you're treating alcohol use disorder, it's naltrexone alone.
Gotcha.
And it's a daily oral medicine, or what I prefer, if I'm in a system that can accommodate it, is to use the long-acting injection. I think it's like 380 milligrams IM once a month, which obviously once a month injections take out the need for adherence. They just require follow-up, right? So I've had patients, like before I came here, my previous institution, where there was a place that I knew that they were going to be hooked up with, and I gave them their first shot on the way out the door. And then within the next month, they would get hooked up with follow-up and they get their next
That's
dose.
the Vivitrol?
Naltrexone injections, if that's the brand name, then
Okay.
yes. I generally try to stick with generics as much as I can, just for ease. But
So, a sidebar of that is that I learned that it messes with their pain. That's the one that changes their pain perception. So it shouldn't have surgery. And it makes sure you're tracking in that month. Are they having any planned surgeries?
So what that is getting at is that naltrexone has its site of action is the opioid receptors.
Right.
It's not like naloxone or Narcan, which is a pure opioid antagonist, but it's like a weak mixed kind of deal. And so if they're on opioids already, you would not want to start naltrexone.
Right.
Because it could precipitate withdrawal. If they're going to be getting opioids, say perioperatively or whatever the case is, you would not want to do that. So that's a good point. And then end-stage liver disease cirrhosis is considered a contraindication for naltrexone. I don't think it's been super well studied as far as what are the true risks of that, but there is a side effect of some increases in LFTs and things like that. So I think they make it a contraindication. So this guy has cirrhosis, so we're not able to use naltrexone in him as much as I wanted to. So we went to second line,
Gotcha.
which is acamprosate. Acamprosate can be used in patients with liver disease. However, it is renally cleared, so if they have renal dysfunction as well, they have cirrhosis and CKD, you would have to renally dose it. But like I mentioned, acamprosate is a kind of a cumbersome 3 times a day medicine, so CKD offers a little bit of an advantage in that you wouldn't have to take it as often, but you obviously don't want CKD for that reason. So acamprosate 3 times a day is what we're using in this patient. And then beyond that, you'll sometimes see other things used like gabapentin, which has some evidence for reducing cravings and some other things, but that's beyond those first 2. So I think getting comfortable with those first 2 and knowing how to start them and thinking about it when you see a patient, just telling people to try harder is not the move. The NNT for naltrexone is shockingly low. I think it's 12 or something like that. For the outcome of sustained, being off of alcohol at 1 year or something like that. So it's quite good, right? Acamprosate, not quite as good, but if it's not an option, then I'd rather than be on this than have nothing and just, tell them, do better this time. That's not how addiction works. So, make sense? Questions on any of this? I mean, this is going to be very helpful for you in the ER in the future because you're going to see plenty of these patients rolling in and thinking about what are these complications I need to be tracking on. Thiamine, heart failure, pancreatitis, decompensated cirrhosis being the big ones that we see most often.
What are your thoughts on antabuse as far as the
Antabuse or disulfiram?
right? As far as
Yeah.
being used in what setting?
Yeah, I might have used it once ever. I don't love it. Put yourself in the shoes of a patient. How likely are you to take that?
Exactly. It's rough.
Yeah, take this medicine that just makes me violently ill. If I do this thing that I have a compulsion to do. Yeah, I don't tend to use it.
Okay.
I go for these other ones for sure. Other questions? You will all see this. You will even see this. Cool. Okay, I think that's it. Thank you.